This excellent medical student-led podcast is for educational purposes only and not intended to be used as medical advice under any circumstance. Welcome back, everyone. This is take number 2. I forgot to click join audio, but thank you for joining us again. This is our 3rd episode this month. We've been really busy. We're excited to have Brinda back, who's going to be presenting a case today.
Hey, everyone. Glad to be back.
And then we have 2 new discussants with us. I'll let them introduce themselves.
Hi, my name is Emma Ryan. I'm a 4th-year medical student here at Rush, applying to general surgery this match cycle.
All right. Hi, everyone. I'm Susan Mari, also a 4th-year medical student at Rush, and I'm applying emergency medicine.
And then, as always, we have Dr. Abrams here with us, too.
Yep, I'm Rich Abrams. I am a PGY 45 in internal medicine. Maybe finish my residency this year.
And then I just want to catch everyone up on the team, but Brinda has been doing medicine for her first 3 months of internship, but she's a med peds intern, and today was day 1 of her peds portion that she's starting. So big change for her. We're not doing a pediatric case though. Maybe we will soon, to be determined. But let's kick things off.
All right. So our first aliquot, 75-year-old male presents with altered mental status after being found down at home by his daughter. What are you guys thinking?
Well, I guess from just an immediate EM perspective, I'd be like someone found down. I'm immediately worried about something like potentially cardiac. Is it like seizure, like postictal? Could it be like hypoglycemia? Is there any? Oh, go ahead.
I thought stroke.
Yeah.
Down at home unattended, don't know how long he's been there, and waking up with altered mental status. It'd be interesting to see if he had any other symptoms like weakness on one side, slurred speech, etc.
Yeah. And I definitely want to know how long he's been down for, if the daughter has any sort of way to tell us.
Those are great first thoughts. You're thinking about the big red flag things that you want to rule out. You guys hit a lot of things that are very acute in nature. So if this was something that was maybe more chronic or subacute in nature, would that change what you're thinking?
Yeah, absolutely. I would want to know if he had any transportation aids at home, if he were using a wheelchair or a walker or something that he could have possibly fallen, hit his head, etc. That immediately comes to mind.
Mm-hmm. Yeah, and something more long-term, like just thinking along the line of like chronic organ failure, like liver disease, renal disease, or even things like dementia can just all cause more like chronic changes in mental status.
And this is just an availability heuristic thing, but I was just talking to a family member, a close family friend who's been diagnosed with Lewy body dementia. And so altered mental status and movement issues, that comes to mind.
What about some other more subacute things, like a more chronic picture that maybe then, there's a good example. It's like the pen is rolling and then suddenly it falls off the table.
Ooh, I always think of drugs. Possible toxicity is a big one. Or if he has any substance use problems, that can, I would not be surprised to find someone down with altered mental status in that case either.
Totally. Yeah. I mean, and I don't know if that answers your question about being subacute, but I would definitely think about not just like alcohol, but a lot of prescription drugs, and even over the counter too, but like in our elderly population, like antihistamine, any like sedative hypnotics too that are prescribed, or opioids that they may be prescribed for something. If they're taking them quite as prescribed or forgot and accidentally took an extra dose, can definitely cause that.
Especially in an elderly patient who seems to be living alone, although he's attended by his daughter, apparently close by. If she found him at home, was at least able to drive there or walk over, perhaps being at home alone predisposes him to medication misuse.
Yeah, and great point, Susan, too, especially putting into context, it's an elderly patient. I like to do this with our EM-bound guests. What are immediate things that you need to address as a EM physician seeing this patient for the first time? What are you going to check right away and or give?
Ooh, I love it. I think because the differential is so broad and like the potential for this patient to be quite sick is there. First thing, walk into the room, IV, O2 monitor. I definitely want to get an Accu check to make sure that he's not profoundly hypoglycemic or something, or even hyperglycemic. I think that's probably where I would start. Any other thoughts?
From a surgical standpoint, of course, that's where I'm going to jump. I think Glasgow Coma Scale and ECs, so check to make sure that he's still breathing appropriately, check airway, etc. Breathing circulation, check capillary refill, and see if he has pulses on both sides. At least upper extremities. I wouldn't necessarily go for his lower extremities. You want to make sure that everything next to the heart is working.
ABCs, for sure.
Exactly. And then check his pupils. See if, again, going back to stroke, that will help narrow down your diagnosis as well. If there's any incongruities there.
I also would want to just, after that survey, I definitely would want to do a quick trauma survey. If we're all worried about a fall or a head injury, that's something I'd want to know right away to see if we're going to send the patient to the scanner or not.
Mm-hmm. And even through altered mental status, if he's in any pain anywhere, that fall, if it was a fall, who knows how he ended up down, we're assuming that it is. But if there are any breaks, any pain anywhere, you want to transport with care.
And then just one more derailed section before we move on. Emma, since you brought up pupils, what if I told you his pupils were super pinpoint? What would you be inclined to do?
I would give naloxone.
Nice. Yeah. So that would cover, an acute drug toxicity thing that, whether intentional or not, we could address in that emergency setting.
Yep.
Ready for aliquot 2?
Let's do it.
Great teamwork so far, by the way.
Thanks. I love that you call them aliquots too.
All right. So past medical history includes HFrEF, aortic stenosis, status post-TAVR, alcohol abuse, he quit 30 years ago, and prostate cancer diagnosed 10 years ago.
Cool. So things that are jumping out to me initially are the HFrEF and the aortic stenosis, although it is status post-TAVR. It's just things that, from a cardiac perspective, definitely like cardiac things can definitely cause like syncope, AMS, that kind of stuff. So I would kind of zero in on that. Emma, what are your thoughts?
Alcohol abuse. I just got off my transplant rotation about a month ago, actually. So I'm thinking hepatic encephalopathy. Even if he quit 30 years ago, if that's what's documented, that may not be his day-to-day life now. If he's relapsed at any point, which is common in alcoholism, he could have been surreptitiously drinking alcohol and cause some altered mental status.
Oh, sorry, go ahead.
No, please.
I say that. Well, it's interesting because the alcohol use could be both an acute and or a chronic cause of an altered mental status. Acute, like you said, if there was relapse with alcohol use and he did start drinking again, that could be acute altered mental status. Or if he drank very heavily for however many years, even if he did quit 30 years ago, I mean, the potential for like alcoholic cirrhosis and liver disease causing AMS is there too.
True. He could have a superimposed hepatitis from any other source that could have caused this as well. It's true. Prostate cancer diagnosed 10 years ago as well. It could have recurred and caused, this is where the end of my knowledge kind of comes. I'm not great at oncology, but I'm interested to hear your thoughts on the prostate cancer issue.
I'm totally grasping at straws, but I feel like at some point, if you have trouble urinating and you have to like really, I don't want to say bear down, that sounds weird, but it can like stimulate your vagal nerve, I guess, if you're trying to pass urine. Sure, yeah. So that could cause syncope. I guess I'd get a better history and ask the daughter, like, where was he found? If he was found out in the bathroom, like that suddenly jumps higher on my differential.
Definitely.
I just got to jump in. This has been masterful already. And I say that seriously. You immediately picked out what you're kind of characterizing as the salient features of the case being the history of heart failure and aortic stenosis, but then questioning, it's been surgically repaired. You're not sure how that changes anything. And then Emma brings up that there's a history of alcohol abuse. So that could be something in the background that we have to be mindful of still. And then pulling out prostate cancer in the past, we're presuming treated appropriately and hasn't had issues since. You're already thinking of what would bring that further to your attention? What in the story would change that and cause it to, come closer to attention, which is just great. And this is, 20 words of information. You just did all of that.
They're hitting all the points that I would want to bring up. So this is great. How would you distinguish? So you said if he is like cardiac etiology, that could cause syncope. So how do you distinguish between the different types of syncope, whether it's like neurologic or cardiac?
So any like syncope patient in the emergency department, we're definitely going to get an EKG. And so that's like, I think that's step number one. I don't know, like a history perspective, I want to know what they were doing prior to losing consciousness. If they had any associated symptoms too. So if they had any like chest pain or dizziness or shortness of breath, or they were like exercising and then they passed out, that to me was more cardiac than neurogenic.
Working off that, there can also be an orthostatic hypotension from just being volume down. And with a history of heart failure, you can have this, obviously volume status changes, but I would check his volume status, see what his skin trigger is like, what again was his capillary refill, and see if it could just be he hasn't had enough water recently.
Ooh, I want you to come down in the yard and do some orthostatic vitals. Please.
Happy for the invitation. Thank you.
All right.
You guys want some more information?
Yeah.
Yes, please.
Okay. So the patient had a similar presentation for altered mental status and agitation 5 months prior. Workup at the time was negative, and the patient was started on an antipsychotic with some improvement in agitation.
Okay.
Tempo is queen, as they say.
Yeah.
Sure. So antipsychotics with some improvement in agitation. So antipsychotic use can be used for dementia, for Parkinson's related dementia, for true mental health issues. And actually, it can exacerbate problems in the elderly. It's generally not advised to give antipsychotics to people who are 75 years old and have all these comorbidities. That's my initial kind of thought, but those are the only threads I've got.
No, I think you totally hit the nail on the head. Like I think when we think about like drugs that can cause altered mental status especially in the elderly, like I think of antipsychotics as being one of those categories. So it's interesting that like his agitation is like somewhat improved, but now if we're seeing changes in his mental status, maybe it's time to reevaluate that medication list.
I would be interested to find out if he had a change in his dosage or in his type of antipsychotic recently, because if he's been stable, what's happened in the past 5 months to make him relapse now to this state, or represent rather.
Mm-hmm. It's hard to do a lot with this information, right? Because you don't know if altered mental status has such a broad differential, which you went over. So it could have been a completely different presentation before with a different cause, and now he's coming in with a different ideology, or like you said, it's a change in medication. So
I think Kevin's point about tempo being the queen, king, I don't know, doesn't matter, but it is just like you said. So the question is can you connect the dots between or you can always connect the dots, but how do you connect the dots between 5 months ago and today when the case is presented? So is it the same thing, or is it two different things? And if it's two different things, how do those two things connect? If in fact they do. I like your analogy. I have two analogies here. The pen rolling off the table is what I call the fence sitter.
Ooh.
Right? So a fence sitter is somebody that are sitting on the edge of the fence, and it doesn't take much, depending on how wide the fence is, to push them over.
Sure.
So is this person always sort of sitting on the edge, and whatever happened 5 months ago pushed them over, which who knows what it was, and did they get back up on the fence and did something else? Did something else push them off?
Yeah.
So it's hard to say, but just acute, subacute, chronic. I think you're always asking yourself that question. There's certainly some element of, I would imagine you guys would say there's some chronic thing going on. Whether the acute mental status is how it ties to that, I don't have any idea.
I always think of medicine in terms of Occam's razor versus Hickham's dictum.
Yes, I was saying the same thing.
The simplest answer, with all circumstances being equal, is usually the best, and then Hickham's dictum. A man can have as many diseases as he very well pleases.
You were already alluding to that. Like you were factoring in base rate by saying maybe there was a medication change. I mean, that is very likely, right? Like it's more likely going to be something common, such as a medication change, versus something that we're going to throw at you at a clinical problem solving exercise.
Totally.
Anything you want to add before we move on?
no, I think we can give them more information. Okay, let's give you a physical exam. So vitals, get a temperature of 103.4, heart rate 130, blood pressure 88/45, respiratory rate 20s with an SpO2 of 96 to 98% on room air. He was on alert and oriented to self. Lungs were clear to auscultation with no crackles or wheezing. Heart rate was irregularly irregular at a 3 out of 6 harsh systolic murmur. Cranial nerves 2 to 12 were intact. 5 out of 5 strength in upper and lower extremities, and dysmetria was noted. To clarify, so this patient came in with altered mental status in the ED, and then this was a physical exam when he was seen in the NICU.
Okay.
I love those words, irregularly irregular. I always know what they mean.
Oh man. Well, before we even get there, like the vitals really caught my eye. Like he's febrile, like, and he's not a little febrile. Like 1 of 3.4 is like for sure febrile. He's tachycardic too. I don't love the blood pressure. It's pretty low. Respiratory rate of 20. So, he's definitely, I wouldn't say this is like a stable patient. So I think that has a potential to change management, change our differential. I don't know, anything jump out at you from that?
I would get fluids immediately. Seeing that low of a blood pressure and that high of a heart rate. The temperature, you're right, is astounding, frankly.
Well, and I guess sorry, not to interrupt you, but one thing that we didn't mention in our initial differential was like, this is someone who, if they came into the ED, I think we'd flag potentially for sepsis, especially with the, AMS, got a low blood pressure, tachycardic, high temperature. I think we have to at least explore that possibility.
And aortic stenosis with a reconstruction, that's an itis for infection as well.
Good point. So smart. Well, it says alert and oriented to self, so I'm getting ANO times 1.
Can I ask, because if he's combative or if he's more or less active, that changes things as well. Sluggish versus trying to jump out of bed can point you in one way or another.
Yeah. So he was a little more wasn't combative in the NICU, but what would you think if he was more combative?
I would think I immediately jump to a drug toxicity in that case. It's not often that you see 75-year-olds on PCP, but I guess it can happen. So
yeah.
Very good thought.
I think with the temperature too.
Yeah.
That makes sense. the lung exam being normal, that's reassuring to me that, because I think of pneumonia as being a cause of sepsis in the elderly that you don't want to miss. So the fact that that's a normal lung exam makes me feel a little better. And then you mentioned the irregular heart rate being pretty pathognomonic for AFib.
Oh,
yeah. Like a med student dream. It is. But so the 3 out of 6 harsh systolic murmur. In someone with a history of aortic stenosis, that's what my mind immediately jumps to. For systolic murmur, I would want to know if there's any radiation to the carotids.
Smart. Yeah, definitely. Again, I love vascular surgery. I was telling you guys earlier. So I would be checking all pulses and getting a read on possibly getting a quick ultrasound, like carotid ultrasound on his neck if I could.
Bedside. I love it.
Hey, you just got off. Well, no, you're on ultrasound.
I am.
Right now.
We can use it for everything. It's so cool. Awesome. And then, I don't know, I feel like you're better at neuro. What do you make of this dysmetria?
Again, points to me more short. I immediately think of a stroke type symptom, but that's lower on my differential now that his temperature is 103. Regularly irregular heart rate. So the dysmetria, I don't really know. Although it could be a toxin that affects the cerebellum more so than the rest of the brain, just speaking in broad strokes though.
Yeah, totally. Yeah.
Susan, since you mentioned that you've been helping out do physical diagnosis course with our M2 colleagues, what kind of physical exam findings would you see in aortic stenosis?
I was prepared to teach that today, and my patient was prepared, so excellent question. So I think, and it's funny because the M2s are like, I feel like they just want to be able to differentiate between normal and abnormal. So like being able to hear like where the murmur is, and so hearing it like in the systolic part of the cardiac cycle is just one thing. So yeah, we're always looking for a systolic murmur. Usually going to be heard best in the right upper sternal border. And the reason I asked about the carotids is because classically you'll hear radiation of the murmur to the carotids bilaterally. So yeah.
Great pearls. And then I was asked this, is it an ejection murmur or a crescendo, decrescendo murmur?
Ooh, good question. I think first aid would tell you that it's a crescendo, decrescendo murmur.
That's what I was told.
Okay.
I was there when Kevin was asked this question in front of the whole CCU team.
I think you guys covered a lot of great things. Brinda, do you have anything you want to add?
I guess my only question is, what would you expect to hear with a TAP status post-TAPR?
That's a good question. I actually don't know. I haven't assessed someone post-TAPR.
So I think you like, I'm taking a stab, but I think you would hear, well, what do they replace the valve with? Do you hear like mechanical valve sounds, or do you hear like just normal heart sounds? I don't know.
So I didn't know this until I went and reported to the CCU that a patient had this really loud murmur, and it was because they had a TAVR. So you still hear a murmur.
Got it.
Yeah.
Would it be a 3 out of 6?
Harsh systolic murmur?
Would that murmur be incidental to his postoperative findings? Maybe this is his baseline and we don't need to worry about it as much.
Maybe.
The only other thing I would say, and you guys should bring it up before me, maybe I'll ask you this question. It does go back to his neuro exam, and there's so much here that's pointing towards potential infection, but I have to go back and think for a second about the non-infectious causes because they're always more interesting. And what if I said, if we don't see it here, of course I could ask the question, what if this person was really rigid?
Like lead
pipe? Like when you pulled on their arms, they didn't move very much.
So antipsychotic medication and a fever 103.
Lead pipe rigidity. So that, well, you already said
neuroleptic malignant syndrome. Yeah.
So and you don't think you see it, but you do see it. And if you don't check, you don't necessarily see it. So when I think of particularly high fevers, and so we've got the pediatrician over here, 105 in a baby, you're like, they're fine. but 103 in a 75-year-old, it's like, boy, that's really high. Mm-hmm. And once you get really high, the differential diagnosis of very high fevers in adults actually tends to be non-infectious. Mm-hmm. Infections are, there's a handful of infections that you think, but you should start thinking of these sort of non-infectious causes of creeping in there.
Mm-hmm. Yeah.
I keep pulling more out of this physical as we continue to look at it.
Yeah.
Emma brought up irregular, which suggests AFib. And then I'm looking at the heart rate of 130. What does that make you guys think about? Does that change your line of thinking? Are you worried about anything?
I feel like this is a classic guess what I'm thinking question.
Yeah.
Goes back to that non-infectious cause of non-infectious causes of high temperature and high heart rates and tachycardia.
Are you more worried about that heart rate knowing that it's AFib versus sinus?
That's what I was getting at.
I'm gonna say yes. And there's something tickling the back of my brain, but I can't necessarily I can't necessarily bring it to the
You're basically there. So AFib with RVR.
Yeah.
But what are like triggers for AFib with RVR?
I think alcohol use is one.
For sure.
Yeah.
For sure, yes.
Definitely.
Oh god.
I'm thinking about how an antipsychotic would be metabolized and affected by alcohol use. But what were you gonna say?
I was gonna throw drugs on the pile. I'm sure that can do it.
I think I was asked on the CCU to name AFib precipitants, and I was expected to continue naming them after like 20 plus things.
Oh. So you should be
So
telling.
it turns out everything that you can probably think of can precipitate AFib.
Interesting.
The thing I was bringing up was flavotoxicosis.
That's right.
Oh.
AFib, tachycardia.
Like, see, so endocrine can do it.
Adrenal.
Drugs, you name it.
Yeah. I'm upset with myself for not picking up thyrotoxicosis. Such a good one.
All right, let's move on to aliquot 5.
All right. So we have some labs for you. So labs are pertinent for leukocytosis of 17, lactic acid of 5.8, alk-phos elevated at 256, AST 153, ALT 83, ammonia of 45, BNP 651, a CK of 995, and then a high sensitivity troponin 85.3. And the UA showed 2+ blood and 21 RBCs. In blood cultures greater than 2 grew group G streptococcus. So we gave you a lot there.
Take it in pieces.
Yeah.
All right. Well, yeah, there's a lot going on here. So the leukocytosis to 17 with a lactate of 5.8, I'm definitely leaning heavier toward like sepsis, an infectious cause, pairing that with like what we talked about in the physical exam. That's my first thought.
Yes, I'm seeing multiple diagnoses jumping out at me just from the labs. I agree with you, Susan, on the sepsis front. And then I just keep going back to alcoholism. His AST is about twice his ALT, and higher than we want either of them. So there's that. His high sensitivity troponin is, broadly speaking, through the roof. A heart attack, although you can have elevated troponins without a heart attack.
Yeah, and I'm picking out like the BNP of 651 because I think you can have a really elevated troponin in heart failure as well, right? So,
Do you know why that might be? This gets into a non-STEMI related cause of elevated troponin.
Well, so like cardiac troponin is like released anytime your like heart muscle is strained. So that's how I think of it simplistically. But I don't know. What would you say?
You're thinking along the lines I was, and what comes to mind immediately is like a demand ischemia.
Mm-hmm.
Okay.
Especially given the septic shock picture that you identified.
And then he's got positive blood cultures times 2.
Sure does.
Yeah, and that CK, I know it's like not super specific, but just as a marker of like inflammation, having a really high CK kind of fits with the picture as well.
Mm-hmm. So going back to the first aliquot, you said he was found down. So that plus like the CK, is there anything that you would want to consider, allow?
Yeah, for sure. I'd be thinking like potentially rhabdo, which also makes sense with his urinalysis showing 2+ blood.
Mm-hmm.
So someone who's found down on they could have been there for many hours. We don't know. Sounds like we don't have a great history. That's definitely something I'm worried about.
So we gave you a lot of information. If you had to put your money down on, or just like general, like cardiac, infectious, NMS.
Invoke your Occam's razor. What are the salient things of these labs that kind of fit together everything we've talked about so far? What are you most worried about? What might explain a lot? This person is very sick, right? Like there's numerous organ systems involved. Yeah. Is it because multiple things are going on, or maybe one thing kind of caused a spiral down?
I would say, yes, there are multiple things going on, but they're precipitated by one etiology. Well, you said everything can cause AFib, right?
And then, like, what would be another diagnostic thing that you would want to invoke at this point?
Where are you putting your money?
Imaging wise, if I wanted more information, I would possibly get an echo. Really check on the status of his heart, see if there are any vegetations we need to be worried about. Again, if he has this kind of infectious picture with the aortic stenosis as post-TAVR, again, based on what Dr. Abrams was saying earlier, I'm not thinking necessarily as much about an infectious etiology anymore. It sounds like drugs are kind of. I'm more interested in investigating how the drugs would solve all of this.
Okay, interesting.
I'm putting my money on the drugs.
Cool. I'll put my money on sepsis. I think that it can explain like organ failure of multiple different organ systems, especially in someone who has some pre-existing risk factors to be sensitive to damage to things like his heart and liver and all that good stuff. Yeah. So, and I think with the imaging, it's tough because we don't have like a whole history. Like I didn't get to ask a full review of systems. Is your analysis not showing anything? Like typically sources of sepsis in the elderly, I think of like urinary tract infection, pneumonia, lung sound were clear.
Especially with the prostate cancer history.
Oh, yeah, good point. One thing we didn't talk at all about was like a meningitis type cause. So if we're like playing fast and loose with tests, like I would consider a lumbar puncture, honestly. Why not?
And then since you have kind of narrowed in on sepsis, that's what your thinking is heading towards. You always got to think about a source.
Yeah.
You've kind of mentioned some general sources, but in this particular patient, where are you being pulled to as being the most likely source?
Yeah, I don't have a great source. So I would want to do a really good skin exam, make sure there's no like cellulitis anywhere, because that can also be a cause. Like I said, like meningitis maybe. Also like in someone with these like LFTs and maybe a history of cirrhosis, like we could get into like, is there ascites with like an SBP type picture? Is there an infection in the abdominal cavity that we have missed somehow?
So we got an MRI brain, showed numerous scattered small acute infarcts in the supratentorial brain parenchyma, findings likely embolic in origin. You got an echo, you asked for it, EF of 40%, and it did not show any vegetations.
Well, in my defense, I did not ask for an MRI because no one ever gets an MRI in the emergency department.
The non-intensive,
I did not know that was an option.
They handed that to you before you saw the patient.
What kind of ED is this? Yeah. Okay. Well, findings likely embolic. What do you think, Emma?
Well, he didn't have any vegetations at his heart, so that was going to be my go-to. But if he doesn't seem to have an endocarditis picture,
you were thinking like vegetations on the valve.
Yeah.
Okay.
I was thinking valve vegetation. He has a history of like cirrhosis or something. Again, he could have, I go back to what I said before, he could have a superimposed infection in his liver, but that's generally going to be viral. It's not necessarily going to be bacterial thing. But you mentioned SBP, spontaneous bacterial peritonitis, and I'm not sure how that would seed to the brain. But I guess if there were SBP and bacterial seeding of the liver straight through the portal vein and up, I mean, would be the next kind of go. But that's a long way for that bacterium to travel for him to present this acutely. So I'm not thrilled by my own source.
So does the TTE show what you were expecting, or is it a total surprise?
It's not a total surprise. His EF is like a little bit decreased, but not certainly not like severely.
And he has half ref.
Yeah, so we expected that.
But we don't know what his baseline is. So it could be.
Yeah, I think like Emma was saying, like not having any vegetations. Like I read the MRI brain findings and thought that sounded like the typical like shower embolus from some sort of vegetation on a valve. And especially with that history of like he has valve disease, he should be more susceptible to infections on the valve.
So the only other thing I'm thinking, again, kind of from a vascular perspective, I love vascular, is if he did have any atherosclerosis that could have cause seeding there, he could have like a septic source there, but that's kind of gross from the stress. Yeah.
So you're thinking more septic emboli versus thromboembolic, it sounds like, if the TTE did show vegetations.
What do you guys think about the TTE as a diagnostic study? Miss on ultrasound right now.
Well, we know it's not perfect. I think a TEE is more because of clear image. Obviously, it's harder to do for the patient. It's more invasive. And there's a number of reasons why we wouldn't do it. But I guess, so maybe seeing this EF and maybe not seeing any vegetations like doesn't necessarily rule it out. But I still think it's a pretty decent study.
I think I'm going to jump Kevin for a second. Please. I know he's going to ask you this, but maybe at this time it is a good thing to do your problem representation. And if you, because I think these things are stories.
Mm-hmm.
So now I'm asking you in your mind to sort of summarize the story and in one or two sentences. And I think it's useful as a way to sort of organize your thoughts.
So if someone was to just come in the room and didn't hear any of this,
Mm-hmm.
how would you wrap this case up as succinctly as you could with the pertinent things to kind of bring them up to speed?
The assessment statement.
This is my fatal flaw. I always forget how old the patient is.
75.
Oh my gosh.
Elderly. They're elderly.
So you want me to take stuff?
Why don't I start? We can tag team it.
Cool. Tag me in.
Okay. So we have a 75-year-old with a history of aortic stenosis status post-TAVR, heart failure with reduced ejection fraction, and remote history of prostate cancer and alcohol abuse, who presents in the ED after being discovered at home down by his daughter with altered mental status, duration unknown. He has not been using alcohol for the past 30 years. He was treated ostensibly for prostate cancer 10 years ago, unaware of his medications, of his social history currently, but his vitals and labs pointed to second.
Yeah. Oh, so I would just say, great. So I would say physical exam, significant for fever to 103.4, tachycardia, hypotension, clear lungs, irregular heart rate, and initial labs were significant for leukocytosis, elevated LFTs, elevated lactase, concerning for potential infections.
Brain MRI showed numerous small embolic infarcts, likely embolic rather, and TTE was unimpressive.
I think you guys nailed everything.
Another piece I might add in with, we have one other piece of, I think, hopefully pertinent information, which is cultures, right?
Oh, and his cultures.
Positive blood cultures times 2.
Yes, it could be strep, right?
Which we drew
Totally
prior to
forgot.
starting antibiotics.
Yes. Good practice.
So now that you've painted the picture, where are you ladies headed next?
I'm sending the patient to the floor. No, I'm kidding.
You did that already.
I would start him on fluids. Again, due to the fall, make sure that he's not in pain from anything, but control for fever, as long as you don't think you're interfering with possibly further diagnosis, more appropriate diagnosis. I would start on empiric antibiotics. What else would you do?
Yeah.
Would it be empiric?
Well,
Well,
we have our blood culture. So it was
Yeah.
group G strep. So we could target that. I don't know. I still would like a lumbar puncture for some reason. I don't know why, but
That's a good thought.
Yeah.
Would you want any other imaging? Have you covered everything that you want?
As long as we're like throwing MRIs fast and loose, I guess that I would like extend the imaging to the whole spine, just in case we're gonna miss like a spinal like dural abscess or something.
I would
don't know.
also consider not a KUB, actually a CT abdomen pelvis. See if there's further nidus for infection somewhere there, especially given that he has this history of prostate cancer and I
Yeah.
don't know why I keep going back to the prostate
No,
cancer.
that's a good thought.
I don't think anyone would fault you for either of those things. So
Yeah. And like definitely you could just take a look overall at his liver. And then if we're even thinking about SBP, that's not a bad idea. So
Great thoughts, because you want to look for the infectious source. So to kind of round it out then, is there anything else you would want to make sure you've considered all infectious sources? Or are you, again, like we talked about earlier, are you satisfied with the TTE and you've ruled out the heart as an infectious source?
I mean, we could get a TEE for sure, just for completeness sake, we'd get a chest x-ray. Just because we didn't hear anything in the list doesn't mean there's nothing there. So we could just rule out pneumonia that way as well. Yeah.
Alcott 7.
So they got a TEE. It revealed a prosthetic aortic valve with a 1.4 centimeter to 1.2 centimeter highly mobile vegetation present on the prosthesis. A region of echolucency encasing multiple echodensities was seen at the aortic root at the level of the non-coronary cusp, consistent with a complex abscess and a complex echodensity present on the prolapsing segment of the mitral valve. That was 0.7 into 0.5 centimeters, likely representing the vegetation.
Hey.
Master abscess.
Okay. Well, I guess we have a source, so
Yeah,
that's good.
we do. And that nicely kind of ties everything together, all of his labs, his altered mental status, his heart issues, his past history fits nicely in there. Cool.
Want to walk through how it kind of ties everything together pathophysiologically?
So he has emboli to the brain, has this very septic picture, multi-system damage resulting in this leukocytosis, as well as an elevated CK, BMP, lactic acid, etc. Those are kind of my initial thoughts. If you have anything to add, that'd be great.
No, I think that makes total sense. And like the idea of it being like an acute on chronic problem kind of fits the presentation as well. Yeah.
I think you guys mentioned it earlier, showering emboli, right?
Mm-hmm.
That could be a good explanation for kind of everything we've seen.
For sure.
This was the last aliquot, and it was very revealing. But why don't put into context everything we've had? What would the final diagnosis be?
Ooh. Okay, so I would say this is a gentleman with septic endocarditis, probably. Yeah, it's on the valve. I would say this is septic endocarditis with septic emboli to the brain.
Yeah.
And then do we, microbiologically, are you satisfied with blood cultures that we had earlier? Do you suspect that does that kind of fit your mental representation of a prosthetic endocarditis? Or would you keep searching?
I would try to get a sample of it if you can, because I also think of group A of staph actually causing an endocarditis picture, although that's usually more likely on the tricuspid valve. But given how long this has been going on and his predisposing factors, I wouldn't be surprised if it were multimicrobial, polymicrobial. Rather.
Yeah, and I think you also have to worry about like biofilms and like resistance and that kind of stuff. So I think it's okay to start broad and just cover what we think it could be. But you're right. I totally think about staph, like staph
Epidermis.
Staph aureus, in addition to some of these strep as well.
Mm-hmm.
So final diagnosis, you guys got it, prosthetic valve endocarditis with group G strep, complicated by septic embolic phenomenon.
Phenomenal.
I mean, both of you said endocarditis
Really,
and multiple
I bought 3, I heard it.
As soon as the chapter was brought up, yeah. So we tried to throw you off, but you brought it up multiple times.
And I think Emma said, "Oh, he status post TAVR. Like that's just a nidus for infection."
Yeah.
100%.
There were a lot of distractors, and I think you guys did a great job of keeping everything in context and kind of reframing your thinking. Just overall very impressive. I'm still thinking back to the second aliquot with his past history and how you guys kind of navigated through that and really set yourself up for this case. Brinda, do you have anything to add?
I think that was a great discussion, and you still kept it pretty broad, even with that fever, not just zoning in on infection, which I think is important to not anchor. Again, great discussion. I'm blown away.
So I got a couple comments. Maybe I'll ask you if you know the case, because I'm sitting here thinking group G strep, which I don't know very much about. You'll get to your teaching points in a second, but all I can think of is that this guy is horrendously sick, and I sounds bad, but goes back to that vascular surgeon that you want to be. This guy I think is ultimately needs some kind of surgeon, because this thing is now involved not just his prosthetic or whatever they put in there, but it's funneled into his mitral valve also. And I can't imagine that there's any amount of antibiotics that are gonna cure this, but you could tell me otherwise.
So unfortunately, this didn't end very well for the patient. So this was on the MICU. What was a really good teaching point. So similarly, he was in the MICU initially. We got the TTE and there were no vegetations. And so we figured, okay, this isn't endocarditis. There's another infectious source. In the meantime, he actually stabilized with the antibiotics. He got a little bit better. His mental status improved. And we transferred him to the floor. And then he got the TEE and got sent back to the cardiac ICU. And then happened to code in that cardiac ICU, was brought back to the MICU. Unfortunately, didn't make it because he showered more septic emboli to the brain. So, very unfortunate ending, but again, a great teaching point that you can't really rule out with TTE.
Yeah, I'm never going to forget that now.
Something I've kind of picked up, I think it was both in the ED and then being on the cardiac intensive care, is TT is great to rule in. If it's there, you can stop, but if it's negative, you keep going. If you're thinking about endocarditis.
I've got my own list of things that you never trust. Never trust the whatever the scans. So I think about CTs for subarachnoid hemorrhage, right? That's a ER thing, right? So it's negative. That's okay. I think of CTs for epidural abscesses because they often don't show up, and so you never be fooled. And then TTEs for endocarditis if you have strong suspicion because they may not show up. And so it's that little kind of list of those things that you say, okay, but I should get the next test no matter what.
And then one more to add on to that is left atrial appendage if you're suspicious for a thrombus there.
Yes.
And setting an AFib.
Yeah, right.
So along those lines, I found it very surprising that apparently the average detection rate with TTE is about 50% for endocarditis. I didn't know that until I read up more on it. But
Want to walk us through some teaching points?
Yes, let's do it. So since we're already talking about kind of the sensitivity of TTE versus a transesophageal, so we can start with that. So again, 50% average detection rate with TTE of endocarditis. And I found that vegetation size also affects the sensitivity, which is interesting in this case because it was a big vegetation, but apparently 25% if it's less than 5 millimeters, and then 70% of those between like 6 to 10 millimeters are seen on TTE. But when you have underlying valve disease, that also affects the sensitivity of TTE. So I was like reading a couple of papers where they also recommend like even sometimes TEE doesn't show it with these prosthetic valves, and that you would get further imaging with like CT chest. So I didn't know any of that. So that was interesting. But generally for infective endocarditis, so infection of the endocardium, like you guys talked about, typically caused by bacteremia secondary to like dental procedures, IV drug use, like a distant primary infection, all of which you talked about as a nidus for infection. We are typically taught to break it down into acute versus subacute, and then based on whether it's a native valve versus a prosthetic valve, it kind of affects the chronicity of it. And then initial symptoms are super non-specific. Systemic symptoms usually have fever, malaise, weight loss, and fever is the most common symptom that you see. I think like 90% of patients will present with fever. And then you use the Duke's criteria for diagnosis. So you have 2 major criteria and then you 6 minor criteria. So the 2 major criteria would be, one, you want like positive blood cultures, but then within that, there's some specific, you need 2 if it's like typical organisms that you would see, but if it's more atypical, you think it can be a contaminant, you need 3 or greater than 4. If you're like you need a majority that's greater than 4 blood cultures to consider it a major criteria. And then you also need endocardial involvement seen on the echo. And then the minor criteria are things that we kind of talked about, but you can have like a predisposition, which you nailed it on the second aliquot. So having a prosthetic heart valve or IV drug use, so you have a predisposition to it. Vascular phenomena, so like septic infarcts. You can see like the Janeway lesions. You can have immunological phenomenon like glomerulonephritis. And then you can also, blood cultures can count as a minor criteria if it doesn't hit those like greater than 2 for the typical organisms that you see. And then just some stuff on group G strep. I know Kevin has some more points, but I was reading that it's actually been reported more now with people with pre-existing valvular disease, and it commonly you see embolic complications with group G strep, and that has like very similar virulence factors to compare it to group A strep with like the M protein, and it's pretty rapidly progressive.
Yeah, I think all I really had to add was because our ability to diagnose and characterize microbiologically, it's being diagnosed more, and we're actually finding that a lot of things that we presume to be group A strep or group G strep. Okay. So you can kind of think of them similarly, causing a similar clinical disease. And then like Brinda mentioned, when it is GGS bacteremia causing endocarditis, they are very likely to have embolic events. Mm-hmm. And then specifically, we always associate IV drug use with Staph aureus, but it's actually a significant risk factor for group G strep also.
Okay. The other interesting thing that I read was when you see group G strep with endocarditis, they're like starting to see associations with colon cancer.
Yeah.
Because I think it's a GI bug. The other thing I will say is we talk about strep viridans, mm-hmm. and strep viridans that's associated with SB, subacute bacterial endocarditis, because they aren't, they're these, you guys told me the word I'm trying to think.
Indolent?
Yeah, they're much more indolent. Sorry, you get old, you forget what they're indolent organisms. And so once this group once you saw strep G here, I knew the outcome was going to be bad because this person had acute bacterial endocarditis, and it goes back to tying those points together. Mm-hmm. He didn't have it 5 months ago. He had it 3 hours ago or something like that. Mm-hmm. And these organisms like dissolve things. That's the way I think of it. I actually think it's actually worse than having staph in some ways, because they make all these toxins, they embolize, they do all sorts of horrible things. And you've got, as I said, he needed surgery. There was no other option for him. That would have been the only thing that could have potentially saved him, because you could already see he eroded half of whatever this thing is away. And so it was a really, really virulent bug. And that was, once you saw that, bad things were flashing, and a bad outcome was coming with him.
Well, thank you, Emma and Susan, for coming on and being discussants. You guys did fantastic.
You guys were fabulous. You were great.
And thanks, Brinda, for coming back to present a case. Have fun in the peds world. And then to everyone listening, good luck to all the M4s applying right now. URAS is coming up in a week. Excited to hear where everyone ends up.
Thanks again for listening. Person, time, and place. See you next time.